time for us to start the last session of the highly memorable midterm conference of AIOS. I am just taking a roll call. Dr. Harshul is not here. Dr. Satyajit, Dr. Arjun, no. Dr. John Sarkar, okay. Dr. Devaprasad Gopal, speaker. But I know he has boarded the flight from Bangalore. This much is on the social media, so he should be here. Dr. Jay Gopal Agarwal is there. Subhash is there. Sugata should be here anytime. Dr. Anil Kumar Singh, not there. Dr. Rajesh, he'll be here. So I think we will start off, all right, without any further delay. The first speaker is Dr. Jay Gopal Agarwal. Topics नहीं है I think the list is little different, yeah. So yeah, Subhash, yeah. So we'll be changing the order. Dr. Subhash Prasad, frequent pre-existing posterior capsular defect. Over to you, Subhash.
सुन के जाएंगे नहीं, इतना तो इंटेलिजेंस है मेरे पास नेचुरल, क्योंकि आपका आर्टिफिशियल इंटेलिजेंस में है। Protocol has loaded, so I think you will be here. So good morning everyone. This is the last session of this first midterm conference, and I would be talking on TECO in pre-existing posterior capsule rupture. So introduction is that pre-existing PC defect is always challenging in managing these cases because of high chance of the nucleus drop and vitreous prolapse, and the choices of intraocular lenses are also very limited. There are so many causes of pre-existing PCR. We all know that posterior polar cataract can have, but I won't discuss posterior polar cataract here. I would basically focus on trauma, that is more in open globe injury, past pana vitrectomy procedure, post-intravitreal injection, and some of the congenital cataract. This is one of the slide pictures of post-traumatic cataract. You can see there is just big tear in the posterior capsule in this post-traumatic eye. This is posterior lenticonus, known to have PCR during the surgery. This is a case of post-intravitreal injection with PC defect. So these type of cataract generally have a rapid onset of progression, and there can be some history of trauma, intravitreal injection, or history of undergoing past pana vitrectomy. And in the slit lamp examination, if the cataract is not total or not matured, you can see the posterior capsule defect. And there are some other clinical signs also, like pistil signs, white demarcation line, or sometimes white crystalline particles floating in the vitreous. So how to confirm? So clinically you can see on the slit lamp, and you can sometimes just for demonstration purpose you can do an entry-segment OCT, simple imaging, and if the cataract is total or dense, you can take the help of the UBM or routine B scan. You can see here there is PC defect in this UBM. Just few things about post-intravitreal anti-VEGF injections induced traumatic cataract, because nowadays anti-VEGF injections have become very common, and nowadays not even those who are not giving any intravitreal antibiotic for endop are also jumping into giving this anti-VEGF injection. So there are chances that that can injure the posterior capsule because they may not be well trained for that. So if there is touch to the posterior capsule, there can be the PCR can remain sealed, so sometimes there may not be progression of cataract, but if there is bigger touch, it can progress very fast, like in Nozudex injections. So how to approach these patients of any PC defect already having pre-existing PC defect? You have to properly counsel the patient, explaining everything about the risk and challenges during the surgery, and the chances of that you may not implant the lens which the patient is opting for. There are increased risk of nucleus drop, and all these patients should be done preferably under peribulbar anesthesia and treat it as posterior polar cataract. So for that you have to take, you have to keep your parameter as low as possible and as gentle as possible. There should not be any head dissection, no nucleus rotation, and keep always VR backup ready, and 3-piece lenses as backup also. This is just a clinical picture of the post-eccentric patient. You can see big tear here, big tear here. The anterior segment OCT is showing this. This is the C5 imaging. Coming to the just small video of this. There is no hydro dissection, just hydro delineation of this softer cataract, and I just because of the manual irrigation aspiration and everything was going very well, but here suddenly there is vitreous collapsing to the PC defect, so I had to stop. But before taking out the irrigation, I injected distal anesthetic and now going to the Pasplana, taking the Pasplana route to do the intervention. Going to the posterior part actually clears each and every feet of vitreous from the anterior chamber and doesn't allow more vitreous to come into the anterior chamber. And it's also really helpful to take out all the products and put in the in the surface and increase the optic capture with the anterior capsule layer. And we'll use translunon at the end just to see that there is no vitreous stem there in the anterior chamber. This is a case of post-Ozurdex injection. This you can see big tear there. I won't want to go into the detail in the surgery because of the paucity of time. Coming to this post-traumatic cataract, the picture which I just shown here, shown in the previous slide. Small video of clip of that. After doing the anterior capsulotomy, I am just using the irrigation, aspiration irrigation to take out the blue cortex as known as such. And there is a big PC defect there in the, as soon as I take out the cortex, this other layer, this is just here. So again I am going behind, behind and doing the same thing, clearing all the vitreous and taking out the remaining cortex. And it's always mandatory to put these lenses in such situation if there is no enough capsular bag to support the lenses. The same dictum or same principle one has to follow, that use translunon and burning so that we never miss any mistake there in the see, this is the clinical pre-op and this is the post-op picture. This is another young patient who suffered an injury, and actually there was incident amount of astigmatism, so I thought to put toric lens here. Again, it was possible to take out the cataract part with the manual IO, and you can see the big defect here. And the only principle is that never allow the chamber to fluctuate too much, always keep the chamber tight. So whenever you take out the irrigation, before that you have to inject visco from the tripod so that chamber remains firm, and that is the principle one has to follow so that you can have intact alloy face without having any problem. So this toric lens has been planted in the bag. There was enough support, so it was possible to plant the lens in the bag itself. This is the pre-op picture and this is the post-op picture. So just to summarize, pre-existing PC tear can occur in certain conditions, and there is nowadays there is rise in incidence of traumatic cataract due to intravitreal anti-VEGF injections right and left, and that these patient needs careful pre-op evaluation and meticulous and patient surgical approach is needed, and always treat this patient as a case of posterior polar cataract with PC defect. Thank you very much.
Thanks a lot, Dr. Subhash. Wonderful presentation. Any queries, any questions from the house?
Sir, you use actually a scaffold only when there is chances of nucleus drop. But in these cases, since there was not a very hard nucleus, so it's not needed. But otherwise, one can always use that. It's a very good option.
So there are few comments. Subhash has been so comprehensive. There's nothing much to add. So one thing I would like to add is free of evaluation. You know, a 20 megahertz ultrasound probe functions better than a taking 10 megahertz probe. And earlier on, we used to borrow this thing from the gynecologists. They use a 20 megahertz probe. Number one. Second thing was the surgeon also. It helps if the surgeon is conversant with SICs.
Yeah.
Because at certain points when you know that the needle is about to go down and you don't want to have a two-stage surgery, if you can do an SIC, then you can finish off the surgery in the same sitting. The third point is now you demonstrated the 3P soil injection pretty well. Now what has happened is initially you are getting it from Johnson & Johnson sensor Air 40. It is not available in many products, so we have to use other Alcon lenses. So
now the Oro, Oro is coming out.
Yeah, Oro requires a much, I think, bigger incision.
But sir, I'm using the B cartridge of the Alcon for that, so it's going to the
B cartridge requires, if you require 2.8 is C cartridge.
No,
B
sir.
Cartridge requires more than
No,
3
sir,
millimeters.
C, I'm using C cartridge.
C, yeah.
C cartridge.
So
B requires 3.2.
Yeah. B requires a larger
Yeah.
device. And many of these cases actually, for example, the toric pattern that you showed, we don't overhide those cases because we do not want the lens to rotate. So maybe just put a suture and remove the suture after a week instead of over inflating the capsular bag may help in those situations. Otherwise, it's a lovely talk. And over to the next speaker.
Thank you, sir.
Dr. Devaprasad Gopal is here. Dr. Anil Kumar Singh.
This is given for CNBM, the wet AMD. It won't, it is a treatment for that.
Gopal is a brilliant cataract surgeon from Bangalore, and he is talking to us on SICS Pro, giving cosmetically good results every time. Over to you, Gopal.
cortex has been aspirated out, the things become quite easy after that. So next step would be to place the intraocular lens. So the intraocular lens IOL has to be placed inside the bag. Now that we have a good view of the capsular margin, we can insert the lens under hydroimplantation by keeping the Simco inside at the edge of the sclerocorneal tunnel, and then push the lens. The first the leading aptic goes inside the bag, and then later the trailing aptic is dialed inside. The entire now the IOL is inside the bag, and then the side ports are hydrated. And this is the end of the surgery, and the conjunctiva is closed by just approximating with the forceps. So this is a cosmetically appealing surgery because bone do not need to be patched. This is another case of soft cataract wherein the side port incision is made. There is a good glow, so that is why I am not staining the capsule. Viscoelastic is injected, and then with just pushing the eyeball, I get a good retroillumination. With based on that, I just do a CCC. CCC is done by just lifting the anterior capsule, having a nick, and then going circularly. So all the steps are done topically, and the patient is not experiencing any pain. The capsular edge is round, central, and it is equidistant from the margins. And now the conjunctiva. Conjunctiva is just peritomy is done by using a crescent blade instead of a scissors. This ensures that the dissection is minimal and the bleeding is less. So the incision is made with the crescent blade itself, and then the sclerocorneal tunnel is made by bringing moments, bevel up and bevel down. The sclerocorneal tunnel ensures that the wound is self-sealing in nature. So this technique involves delicate holding of the globe, where the wound is not supposed to be tampered with, and care is taken there so that the wound is not to be touched with the forceps. AC is entered with the keratome, and it is extended at both sides, and now you can see the excess margin which is round and central. Now just inserting saline by in the form of hydrodissection, which is a cortical cleaving. You can see the nice golden ring, and then it is hydro is done at both the sides, and the one pole is lifted into the anterior chamber. Once the pole is collapsed into the anterior chamber, the rest of the things, the cavecties can go inside the posterior lip, and then the nucleus is delivered out of the syncytium. So next is your epinucleus and cortex, which can just be aspirated or just press the posterior lip, and the cortex just comes out. So this is one easy technique where you can give a cosmetically good looking eye, and atraumatic, and it is painless. So finally the cortex is being removed, but starting with the side port incision. The cortex is removed from the edges of the capsular edges of the capsular opening, and then finally the subincision cortex. So this technique ensures that the patient doesn't have any pain, because we are not touching the iris, and we're not letting the anterior chamber collapse at any point of time. So in that way, the side port incision is of a great help. And finally, when you're implanting a lens, you can either do it with viscoelastic, or you can just use a Simco cannula at the edge of the tunnel, and then push the lens inside the bag. First the leading aptic goes inside, and then the trailing aptic. So that is about MSICS Pro, which gives results on par with phaco, and the post-op recovery is good, and the patient doesn't find a difference between two of the techniques. So I would like everyone to start doing MSICS in a topical way and give good results to the patient. Thank you for your attention.
Thanks a lot, Dr. Gopal. Very nice videos. Any questions from the audience?
Sir, what are your views on this topical SICS? Would you, in your private practice, would you prefer this method?
No, so if these are the cases that I was doing, I would do a topical clear corneal temporal phaco. All right. So even if it is a, let's say, outreach program patient, I'll still use hydrophilic acrylic lens, but to a phaco. But then this is a question of, I have actually been doing this technique for more than 30 years. What Gopal has shown, it's a deja vu for me. So this is a good technique, and it can be done under topical anesthesia. It is somehow a myth that SICS has to be done under peribulbar or subtenous. No, it can be easily done under topical anesthesia. Maybe in certain patients where intraocular manipulations, you can use intracameral Zalocard. That's it. But otherwise, it can be done.
But every time you're holding the conjunctiva, the patient doesn't feel pain?
No, he doesn't feel pain.
He has used a proparacan eye drops.
Proparacan eye drops started the surgery. Then hold this thing and ask the patient to keep looking at the light. He should not move his eyes. He doesn't experience any. No need of giving any subconjunctival.
But all's well until everything is going well. Once any complication happens,
then you can just supplement it with the subtenous injection. Subtenous you can give and then continue with the case. Especially so in hard of hearing patients, hard cataract, pseudo exfoliation. Better to avoid topical in such cases. You can start as a topical and then you can supplement with the subtenous.
After this procedure, you are immediately.
I'm not patching it. We start with the post-op medications and the patient is followed up the next post-op.
No, same day sent home after 2 hours or immediately?
Immediately sent off. No need of patching. Only thing is the hemostasis has to be achieved. You need to close the conjunctiva, approximate it with forceps, keep it for a few seconds so that it gets attached. Patient does well. Intracameral phenocaine, I use only intracameral. It's preservative free. Initially it helps you to have a painless CCC and all this, but phenocaine does help in cases where there is minimal dilatation or the patient has not put the dilating drops before surgery. It helps, but not as good as dilating drops 1 hour before surgery.
But it dilates pretty well for phaco and eyepiece candidates. So whenever I have an eyepiece candidate patient, the pupil is less than 6 millimeters, I always use phenocaine drops.
Generally in the SICS, we are a little further away from the limbus when we are making the incision. Such a large incision, what are the issues with astigmatism?
Astigmatism, if you are doing it superior temporally, for right eye SA, if you are doing it superior temporally, the incision can be as, depending on the K1, K2. Here the incision was very near to the limbus because the K1 reading was a little higher than the K2. If you titrate the incision based on the keratometry radius.
So any further questions for Dr. Gopal?
Okay, thank you.
From the audience?
Madam.
Okay, so thank you Gopal, nice videos and good surgery. Next we move on to Dr. Sugata Paul. He will be talking to us on posterior polar cataract. A similar topic I think was dealt with by Dr. Subhash, the first presentation that he made, phaco and pre-existing posterior capsule defect. So over to you Sugata.
For giving me this opportunity. So I'll be speaking on managing posterior cataract, but my talk is what beginners should learn more. Now it is every step which the beginner should practice in normal cataract before proceeding to polar cataract. And have a look at this case. Sorry, it's not playing. Someone else can do the talk, next talk, because there is some connectivity problem. Shall I play from my pen?
For the interest of time, we will ask Dr. Jayagopal. Yeah, artificial intelligence tools are as good as experts in diagnosing eye problems. Future revolution.
Dr. Agarwal, you present, I think we'll try from that computer. It's not playing. No. See, I've given my pen drive also.
Now my topic is artificial intelligence tool as good as expert in diagnosis eye problems as in future evolution. Artificial intelligence is simulation of human intelligence process by machines, especially computer systems. These processes includes learning, acquisition of information, and rules for using the information, reasoning, that is rules to reach the approximation, and the definite conclusion, and lastly, self-correction, that is self-validation. I'm not going into detail about the where it is used, but what is the basic of artificial intelligence? There are 3 or 4 steps, but generally for us, it is a deep learning with convolutional network. And here, all the data are input inside the input layer, and there are multiple layers here that that after crossing each layer, our data is validated and corrected, and lastly we get the output as a very correct result. Now, this is a data-driven machine, but here it is at the already supervised. That is already data is in the cloud, and we just after catching the picture from fundus, and we transport it is transferred to the cloud, and then it is processed, and we get the correct result. Now, another problem is that with artificial intelligence, that is, as far as supervised learning is concerned, it is good. That is, till now they have the machine learning algorithms are supervised learning algorithms, because its output based on the presence of the same image characteristic that is human would identify, and the scientist can adjust the algorithm if necessary. That is, this is controlled process. However, the Google developed a successful system of Google Brain in 2016. Now, it is an unsupervised black box system where the Google deep learning algorithm teaches itself, not fitted by our human scientists, to correct and identify the diabetic lesion and photographs, even though it is not told that the lesion is looked like. Even then, it estimates, even it is not fed in the data, then even then it gives the result. It is unsupervised black box. So unsupervised system unsettles some specialists with the fear due to unsupervised approach, but fascinates others as a complement to the skill of physician to provide better care. This is a black box phenomena is shown in this picture. Here the data is transferred to the clouds, and even the data is in the system, it is not fed by the scientist, and even then after the black box, it gives the almost very correct result, but sometimes it gives the wrong result also. That is the danger. Now, artificial intelligence is as good an expert in diagnosing the eye problem. Now, serious question is, will it replace the ophthalmologist in future? The role of doctor will continue as a master of art of medicine, which is uniquely human process. So, here is the catch, that if you go for the diagnosis for retina in the diabetic retinopathy, here it can be both offline and online. Generally, we have got the devices with offline, but online is also there, where the data and photographs sent to the cloud of database online, and it can be analyze results immediately, and then major players are Google, Microsoft, IBM, and other centers. But it is a very costly affair because the software is costly. The offline analysis is we have with us in some centers in our country, but here the data and photographs are sent to the machine itself, and analyze the input that is gives the result. Method has been tested on four public available database, Visitor, DrawNP2 and the DryB1. The image is obtained from the local eye hospital. It is commonly practiced in our countries in many satellite centers. The process is sensitivity is 92% and the accuracy is 93%. This is the picture we give to the machine taken from the camera, and when it is put offline, then we detect the diabetic retinopathy and the diabetic macular edema from the fundus photograph. It is a potential to provide more efficient and objective analysis of the image prediction of the disease. Now, IDX DRC is the first device in ophthalmology to approved by the FDA using the artificial intelligence. Here, the software program incorporates the deep learning enhancement algorithm. The two images are taken, one at the macula center and one at the disc center, and taken a non-magnetic retinal camera. Usually, it is used by the Topcon, and digital images of the patient are uploaded to the cloud server and the IDX DR software. Two types of results come in. One is the negative for more than mild DR, that is for the here the patient is recommendation for the up to 12 months screening again. Then the positive mild to mild than more than mild DR, it is referred to the eye specialist. So here the sensitivity is 87% and specificity is 89%. It is very easy. It can be handled by the non-eye care professionals. It can be it can be applied also ROP and it can detect the ROP in very early stages. Now ARMD, it is a very important role in monitoring therapy of the effective ARMD to find out the fluid collection, quantify the amount of fluid and determine whether the disease is more active or less active than the before. Prediction of earliest ARMD based on doses, prediction of course of the disease, and individual treatment intervals when to give the intervention. There is also it helps in the corneal topography. In IL power selection, we have Hill RBF formula and LEDA super formula. It is both are the artificial intelligence based formula. Keynes formula is also artificial formula. Now, to current limitation of artificial intelligence is the quality of the training sets, the problem of image quality, black box dilemma, and the sometimes the wrong answers like false negative that is called adversarial images. Now for these, though there is many problems, but still we have valuable. It is a very valuable research tool and definitely huge role in research and hypothesis generation recovery. And there is augmentation, not replacement of the ophthalmologist. The final decision of management will depend upon the specialist. Mechanics of machines are help the doctor for better diagnosis. The role of doctor will continue as a master of art of medicine, which is uniquely a human process. Whatever be the pros and cons, artificial intelligence is going to transform our healthcare system. It is going to create revolution in ophthalmology. Thank you for your kind attention.
A very nice talk, Dr. Agarwal. So, Sugata, you ready?
Yeah, I'm ready.
Yes.
So I was on my.
You have the questions after Sugata's talk.
Yeah. So probably this is the last talk of this session and the conference. So we had a great meeting. So I was talking about posterior polar cataract. So beginners should master each and every steps of phaco, such as, for an example, the sections. Here I am doing a keep a eye, and here I am doing a topical phaco and doing a side port. What is the problem? I don't. And have a look, the patient just moved his eyes and the section enlarged. So you have to be careful while doing a PPC, where the chamber maintenance is very important. So I should have holded the blade other side round, because normally the patients, they move their eyes upward, and because my blade cutting edge was downward, it extended. And now the problem starts, especially if you're doing a PPC cataract, the chances of the posterior capsule opening becomes imminent. So the second thing is the section. For section, they do in the different way. What I normally do, nick the anterior capsule with the keratome blade itself. That is not the point which I am trying to show, but what we do, the flap is already raised, and then try to keep the rexis slightly on the smaller side, say 5.5 or 5, so that if you are doing a 3-piece IOL insertion, if the posterior capsule open up, if you are doing a 3-piece IOL insertion, you can always do a iris capture if you have a adequately sized rexis. So second thing you should master as beginner is the rexis. And once you have done the rexis, the next step is hydro dissection. Now hydro dissection is a big no-no for the beginners. I know there are seniors who are talking about hydro dissections because they have the anterior segment intraoperative OCT, but otherwise you shouldn't. You either take a spatula, separate the capsule, anterior capsule from the thing, or use little bit of hydro fluids just to separate the anterior capsule. So this is what you should do. Now regarding the management of the nucleus, again chamber maintenance is very important. Here what I am showing, I haven't done any hydro dissection. No rotation of the nucleus should be done. In soft cataract you can just engulf it, but little bit of hard cataract, what I have done now, I have taken a pie out. Still I am not rotating. Instead of rotating the nucleus, I am rotating the tip of the phaco and bringing it at 3 o'clock and trying to get another piece out. So once you have done that, you can engulf it. So you now have 50% of your nucleus out. So now if you drop, you have to pay your colleague only 50%. Okay, if you have to pay your retinal colleague only 50% if you drop the nucleus now. Now what I am doing, I am just trying to get hold of the upper half, nudging it out of the capsule without rotating, and then chopping it into pieces. So what I have shown is, without rotating the nucleus, you can effectively do phaco in posterior polar cataract. And as a beginner, you should practice this in normal cataract without hydrodissection. Try to rotate, and then you can give up and hydrodissect and do the thing, but you should practice in this normal cataract. Now important thing is not to decompress your chamber. So what you have seen, what I have done, instead of taking the phaco piece out, hand piece out, I have used my visco to form the chamber, then taken the phaco piece out. And what I am doing next, if you remember, initially I separated the capsule. From there now I am injecting visco, you call visco dissection, and separating the nucleus up to the attachment of the posterior pole. So then it becomes removal of the epinucleus much easier. And what I am doing now is using my second handpiece is my visco cannula, so that whenever there is any chance of decompression, I am injecting visco to maintain the chamber. So once the epinucleus is out, you can inject little bit of more visco and then take your phaco tip out. So the chamber is maintained. Now regarding IA, IA is very important because you don't, 90% of the job is done. You don't need to have lost for the last 10%. So it is important that if a pupil is small, you can manage either with iris hook, or you can just nudge the iris away with the second instrument. But important thing is that don't try to polish the capsule. In PPC, you can always do YAG later on, or if you are a pediatric surgeon, okay, you can open up the capsule, do a rexis, but if you are not, then don't try to polish the capsule. As you have seen, a fool like me, I tried to polish the capsule here and the PC opened up. Luckily, it was not a small, big opening, it was a small opening, and I managed to put the lens in the bag. And as you see, I have kept my irrigation on, not allowing it to decompress, so that the it's not opening up, and then I managed to put the lens in. And if the PC open up, you need to know how to manage your case, or you have to take help of your senior, because if you are trying to do initial phase, you have to take your help of the junior. Here the PC opened up, so after putting good amount of cohesive viscoelastic, dispersive viscoelastic, I am trying to get move the little bit of cortex which was left. So here what you do, you try to move it in a sideway fashion and then bring it out, and always try to maintain the chamber. And once this is done, then you have to reassess whether you can put the lens in the bag or whether you can put the lens in the sulcus. Preferably, I think we should try to put it in the sulcus, because you don't know whether while injecting the thing it will open up. So here I am putting a 3-piece lens. As there are several ways of doing that, what I am doing here, I am directly going in between the capsule and the iris, but you can always press it on the iris and then put it back. So whichever technique you are familiar with, you can use. So once you have put the first haptic between the iris and the sulcus, then you can dial in, or you can use a McPherson to put the capsule, put the trailing haptic over the anterior capsule. And always remember to use triamcinolone to make sure there is no remnant vitreous. Whatever vitreous there in the anterior chamber, you can go in and trim off whatever vitreous is there, and then you can use pilocarpine as well to see whether there is any peaking of the pupil. That also can give a hint, and then form the anterior chamber. Here I couldn't show the iris, capsule capture very well, but that's how you progress. So I think it just okay, it's causing some problem. So I'll end my talk here. Thank you for your patience hearing.
Thanks a lot, Sugata, for a very lovely video presentation on the posterior polar cataract. Any questions from the audience, or anybody wants to add some points to what has already been spoken so far? Yeah, Harshul?
Sorry? Yes, so that's what I showed. If the PC is ruptured, yes. So the last video was with the large, if you have noticed, it was a vertical split of the posterior capsule. The last video was a vertical split of the posterior capsule, where I decided to do the lens on the sulcus and did vitrectomy. So that is important to do. And if you have a PCR while doing the phaco, if it opens up and there is nucleus drop, then you have to take help of your colleague. First vitrectomy if there is vitreous, then lens. So here it was opened up, vitrectomy was done, then I did the IA and then put the lens, then whatever remnant vitreous was there with triamcinolone, I cut it off.
So just to highlight this point, if you're just a sec, just to highlight that point, if we are sure about the anterior capsular integrity, you have an intact rexis,
yes,
and rest of the capsule is fine, then even if the PC rent is very large, even larger than what you had shown, you can still keep the lens, 3-piece lens in the sulcus with an optic capture.
Yes.
That gives a very stable, it locks the lens pretty well for times to come.
And I think for the size for the capture should not be more than 4.75 or 5. So then only you can capture it very well. So the size was a little bit larger.
Yes, for this it was 5.5. Yeah. So that's what I said. It should be between 5.5 and 5 rather, so that you can capture.
4.75 to 5 is ideal size.
Now see, when we make a rexis, we don't really measure it, but the dictum in a posterior polar cataract is don't make a large rexis.
Yes.
That is, don't make anything more than 5.5.
Yes.
4.5 to 5.5 I think is stable. It's basically that you need a good uniform overlap all around. Otherwise it may again be pushed out of the bag, and it may lose its stability, and it may, the power may change. Yes, John.
See, in this video I was using Centurion with 90, so I not, sorry, Infinity So I normally keep it at 110, but it was 90, so I didn't pay any attention on that. Sorry. Huh. IOP normally my IOP nowadays varies from 20 to 40 for Centurion. Oblique shape, someone proponent that you
Oval
can do
rexes,
applique capture.
oval
Oval,
rex,
yeah. Yeah.
But I don't think that it can anyway save you from, you know, in a true posterior polar like this where it has to open, it will open. It can't save you from this. So I'm talking about true posterior polar, not the subcapsular which looks like polar. Because in the end, it will open up. Like this case was a true posterior
Yeah.
polar where you have a split like this.
So 10% of the posterior polar, I think they open up whatever you do, but you have to be hopeful that it don't open up during the phacoemulsification.
Yes.
If it opens up during the IA or thing, you can pretty well manage them.
See, the thing is, we cannot say that only if the posterior capsule opens up, it is a true PPC.
No.
Because of iatrogenic errors, because of surgeon errors,
Yeah,
it can open up, you know.
Yes.
So that is the reason the oval rexis comes to the picture, because it is aligned along with the paracentesis. So the manipulations and the chopper manipulations become easier. Yeah. But then it is again, it's not that
Chance of
it's a surgeon dependent factor.
See, I think parameter higher will not make a much difference, but if you are rotating the nucleus, that can open up the PC. And one thing is, as Dr. Harshal was saying, that you have to be vigilant, because once I had, it was PPC, I did the phaco, I did the bimanual from one side with chamber maintenance, and I thought, okay, I have done, and I took out the hand pieces to change over the hand that it opened up.
Yeah, I think
So,
we have to put an end to this,
Yeah.
because we are expecting Rajesh and he has come.
Oh, Rajesh, sorry, Dr. Sinha has
We'll
come.
take up the talks later on.
Sir?
So I think we should always be careful that whatever we do, we don't do any manipulation when vitreous is there in anterior chamber. So once we see that vitreous is prolapsed, we should stop then and there, put triamcinolone, stain it, and then do adequate vitrectomy before doing this. And in that also we should know what is cut IA and IA cut mode, beginners, that when vitreous is there first, we need cut IA mode. We need to cut the vitreous first and aspirate. And once everything is done, we can go to IA cut mode. We can do aspiration, yes, cortical matter. Yeah.
आगे क्या? I think maybe size of rexis does matter, as was being discussed. That in case you have a very large opening, then you can put the multi-piece lens and capture the IOL in the.
In posterior polar cataract, most of the time the nucleus is very soft. But if it is hard, then I had seen your video few years back. So that from one you make two port for the phaco needle, which is nearly opposite to each other, so that you don't rotate the nucleus. Instead, you just take it out and that.
Yeah.
And another one video from Tinsukia or somebody, Dr. Abhishek, he had bent the Calvin tip in opposite direction, and that actually can move this side or that side. That helps also.
So, thank you. I'll be talking about traumatic cataract. I have no financial interest. Cataract can happen with blunt trauma or a penetrating trauma. Classically, it is rosette cataract, but there can be all sorts of cataract, like you can have a total cataract, you can have a subluxated cataract, you can have a partially absorbed membranous cataract, you can have lens matter in anterior chamber, there can be associated trauma to the cornea, associated trauma to the uvea, and resulting in traumatic cataract with adherent glaucoma. So all sorts of presentation pattern can be seen, as I've discussed just now about the various presentation patterns. And the aim of management is to do a lens aspiration, place the intraocular lens, and any additional procedure like procedure related to cornea, procedure related to uvea, all these things have to be done. So overall, it's a difficult situation to handle, but yes, it is very gratifying because the patient has sudden reduction in vision and the patient is in panic, and if you provide a reasonably good vision, patient is still happy. As far as cataract surgery is concerned, when there is a trauma to the cornea, penetrating trauma, at that time it's better to repair the corneal perforation and defer the cataract surgery for a later time. But if there is lens matter in anterior chamber, flocculent matter, then in that case you can remove the lens matter, and then later on, once you remove the suture, and then plan for a secondary IOL so that you can have a good biometry, accurate biometry, and there is no IOL surprise. So as you can see here, the lens matter is there, so it has been removed and the patient has been left aphakic. Now you can have all sorts of trauma, like you can have a uveal damage in a traumatic cataract. So trap and blue dye is being used to stain the capsule. Sometimes if you have a very bad damage to the uveal tissue, then in that case you can create a slightly smaller rhexis, because the anterior rhexis margin will pacify and that will act as a pseudo pupil if the patient cannot afford for an iris segment, etc. Now another scenario is presence of a PC plaque. Sometimes what happens that there is a partial absorption of the cataract, and then in partially absorbed cataract, sometimes the cortical fibers become very calcific, and you have to use your second instrument to feed the lens matter. It acts like a very refractory kind of a thing. So that is something that we need to do. And then you can have a PC plaque. Now PC plaque can be three types, two types in traumatic. But third type is seen mostly in VR surgeries. So in one wherein you can create a cleavage plane, and the other wherein the capsule itself is opacified. So here you can create a cleavage plane, and once you create a cleavage plane, you can lift it up with a Utrata forceps, remove it, clear the visual axis, and then place the IOL. I prefer removing the plaque and leaving the capsule intact, because you can have a single chamber, you can have a double chamber, like anterior chamber and the posterior segment, like vitreous chamber. Otherwise, if you cut the plaque with a vitrector, then in that case it will be a single chamber. The risk of inflammatory mediators going into the posterior chamber causing CME, etc. is high. If you have a membranous cataract like this, you can't do anything. You can just cut the central part and place a multi-piece IOL in the sulcus. I'll just skip this video for now. This is another case wherein there is a traumatic cataract in the periphery and there is a scar in the periphery. In such a case, if there is high astigmatism, you can place a toric implant. There is a small zonular dehiscence here. You can put an endocapsular ring. If the scar is in the center, then you put a spherical lens, but if the scar is in the periphery, you can put a toric implant. There can be pre-existing PC defect because the trauma, blunt trauma, since the posterior capsule is the thinnest, so sometimes you can have a PC defect. So if the cataract progresses very fast, in that case you should doubt that there can be presence of pre-existing defect, because fluid will get imbibed and that results in fast progression of cataract. So in such cases, if you wait for some time, maybe about 6 weeks time or so, then you can get a nicely fibrosed capsular margin. So in that case, it will not extend posteriorly, and you can place a single piece IOL in the bag in such a scenario. Otherwise, if it extends, then in that case you have to put a multi-piece IOL in the sulcus and do an optic capture in the anterior capsular axis. Here again, you don't dial the, it's better to do minimal manipulation, so gently caressing the haptic into the capsular bag helps, and that is quite effective. If you have a bad trauma, like this patient had a medical student having a traumatic corneal perforation, iris tissue laceration completely, so repair was done, iris was removed, the lens had fallen behind, for a vitrectomy was done. So finally the patient still had a good vision with contact lens, so we planned to do an aniridic IOL because she was not able to open her eyes in sunlight. So we planned an aniridic lens. Now aniridic lens is a 9mm diameter lens, so you have to create a large incision, but initially you create a small incision so that you tie the knots. So this is a 9-O-proline suture which is being introduced through a scleral groove and exteriorized from the main wound, and then suture are tied around the eyelet. You can do differently also. If you have two sutures with you with both straight needle, you can very simply just pass through the eyelet and take out the two needles. But here, if you have a single suture with two straight needles, you can cut it in the middle and you can do with this procedure. And then you enlarge the incision size and then place the IOL. Now, what is important is titration of the centration. So you tie one knot on one side and then tie one knot on the other side, titrate the centration, and then go ahead with the tightening of other sutures so that you have a well-centered IOL. The central optic cylinder is of 4 millimeters, so it works well. If it's a subluxated cataract, it's a huge topic in itself, so I won't go into details of it. I'll just tell that up to 120 degrees you can manage with an endocapsular ring. Up to nearly 240 degrees you can manage with a back fixation with Sione's ring or a segment. But beyond 270 degrees, it's better to remove the lens in toto. You can do any procedure, remove the lens, and then you can do a scleral fixation of IOL. This was one study which we had published, post-traumatic scar, then there was a cataract. So the cataract surgery was done and we did a sphincterotomy. So this created a small pupil just adjacent to the scar, and that helped in providing good visual recovery. We published this article in the year 2004. And if you have a scar with IOL, you have a traumatic cataract with corneal scar, you put the IOL, have done everything, but still the patient will have a central scar. In such a case, it is advisable to rehabilitate the patient with an RGP contact lens, because that will neutralize the irregularity of the cornea, and that works well and gives the patient satisfaction. So thank you very much for your patient listening.
So I think this is the last presentation of the conference. Last session, last presentation, and by none other than the official of AIS. So that too from Rajesh Jogi Patna ke.
Thank you, sir.
पटना की ये फिनिश एक ही है, स्टार्ट एक ही है, फिनिश एक ही है.
हाँ
So this I presented in 2011 ESCRS in Bob Osher's symposium. So basically I use 1.8 millimeter phaco tip. It's a very small incision as compared to 2.8. So what I realize is many a times in posterior polar it's difficult to take the sub-incisional, rotate it. So if you try to rotate it, torsional forces can open the posterior capsule. So that was the left eye. So I thought I'm sitting temporal and that area is this side. So I went superiorly and went from almost nasal side, so that I made 1.8 millimeter and took this portion also. So the two-port phaco, it helped in posterior polar where you don't want to rotate, so that incision is also not large. So side ports are 1.2 millimeters, and 1.2, 1.8 doesn't make much difference in astigmatism also. Yeah. 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 Yes, so that you don't have to rotate it. So that was two-port phaco.
वो एक presentation मैंने देखा था वीडियो, somebody from Tinsukia or something, like Kelman tip of जो machine का है Infinity का, generally जो ऐसे bent रहता है उसको उसी side में bend किया ऐसे. For removing the nucleus on the left side, he went like this, and for the right side, he went like this. So.
So I think the idea in inside out is also that you first debulk in the center, and when you do inside out delineation, you don't open up. It's not hydrodissection. So basically what we want in a true posterior polar is we don't want to open up. We always want to delay opening of posterior capsule, if it has to happen, so that we have our nucleus out, we have our most of the epinucleus out, So that is layer by layer, we want to take out the entire nucleus. So that's the whole concept. So when we don't do hydrodissection, we only do hydrodelineation. So that is the basic concept of, preventing it. So the thing which I've seen over the years, what helps is only to maintain anterior chamber, to not let the anterior chamber collapse, and to not do hydrodissection vigorous in this. Yeah. See, even I believe that femtosecond can also not help in, true post-polar cataract. No, even if we do OCT preoperatively, the same principle has to be followed. See, after seeing OCT preoperatively, you can't commit to patient that this won't open up. Even a weaker posterior capsule, which is subcapsular, it can also open up if you are not careful enough. So whatever is, so we always have to follow the principle. That if we follow principle, PCR is not a big thing nowadays, The way we do vitrectomy and the way all the machines have good vitrectomy settings and everything is not a big thing. But how to manage it is important. And that's what, paves the future path. That if vitreous is there, we are trying to fishing out the nucleus, we are trying to put the IOL with vitreous in it. And we are, using Sinskey hook to play with the vitreous. So that causes traction on the vitreous base, and that leads to the post-operative retinal holes and all those problems.
What I feel that if the vitreous is not blocked, and if there is a PCR, a simple surgeon can very well manage the going to plasma by side port, just do vitrectomy, cut IA,
yes,
and then IA cut and the irrigation and the anterior chamber, and it can be managed. And all anterior segment surgeon in this era should know at least this much.
Yes, of course.
If the nucleus is dropped, the thing
that is a big debate.
No.
Thing is a big debate.
Yeah.
Because if you do a choroidal detachment, then you will say you are anterior segment surgeon. Why did you try to put in a trocar?
What I feel that plasma is very easy, and nowadays most of the cataract surgeons, they know to manage this much. If the nucleus is dropped, the thing is different.
But if you follow the principle, you can do with limbal root also. There is no. Yeah. Yes. Yes, because whatever defect is there, if you come out suddenly, it will enlarge. If vitreous is not prolapsed, it's not disturbed, it will get disturbed and it will come out.
Even if it's
अच्छा चलो बहुत पढ़ा दिया आशुतोष कुछ फोटो आशुतोष बहुत पढ़ा दिया
if you go lenticle like it was mine, if you go lenticle of the
ऐसा नहीं होता है आ जाओ सामने आओ अरे सर आई प्लीज हमारे साथ होना चाहिए ना
पटना का जमाई
आज भी पटना का जमाई है अरे आओ जमाई what's your good name? This is from Ahmedabad.
Dr. Jitlan is
मैडम से मिलकर
ये अच्छी बात है
Always.
ये ऑप्शन होता है अच्छा लगता है
एक कैमरा
न्यूक्लियर एसिड दे देगा आपका दे दो एलबी को कुछ कर देना रात में
Oh yes.
रात में रात में
chicken
लगा देता है यस मैम सामने
एक सेकंड साइड हो जाइए
how to get the photo
अरे मैं भेजूंगा
you didn't send me last time
कैमरा थैंक यू
Kochi में
अच्छा ठीक है अभी भेजता हूं थैंक यू
Kochi का photo
अच्छा अभी आपको आना है ना